So I'm joined today by Professor Julian Chun, a very good friend. Julian, welcome. Thank you for agreeing to talk with me about PFA and FARAPULSE. Can you just tell everybody a little bit about yourself?
Yeah, thank you, John. It is a pleasure being here with you. And my name is Julian Chun. I'm working and living in Frankfurt, Germany as an EP. And we run a large EP center in Germany, Frankfurt.
Fantastic. Tell me a bit about your early experience with PFA and FARAPULSE.
Yeah, I mean, as you know, we have been the first commercial center being exposed to the FARAPULSE technology. And from the very first day on, we realized this is something which has a big potential because it's speed, but it's also its, let's say, ease and reproducibility of the pulmonary vein isolation did impress all of us a lot.
You say from the first, when was the first day?
It was in March in the year 2021.
Okay, and how many patients do you think you've treated with FARAPULSE?
By now, I would guess, I don't have the very precise number, but it's around 520 cases,
okay,
I guess.
Pretty big experience, a very big experience. What are the main differences you're seeing with PFA for ablation of AF compared with thermal technologies?
Yeah. It is a single shot or an anatomic approach. So therefore, compared to RF point-by-point ablation, it is characterized by, I think, a much greater reproducibility. It's over-the-wire technology, go for the vein, and you don't even have to push that hard. You don't have to need perfect contact as for the cryo balloon, for instance. Some contact is good, but then it is very fast and it's very efficient on a procedural level.
So fast and efficient. Any other comments? Safety?
Yeah, I was just waiting for that. Safety is, of course, the very big promise of PFA because it is non-thermal and therefore it should not affect the esophagus, it should not affect the phrenic nerve, for instance. And collateral damage because it's due to the specific sensitivity of the cardiomyocyte towards electroporation should be better.
So I know that you're integral to the Euphoria registry. Do you want to just tell me a bit about that?
Right, yeah. The Euphoria registry is an initiative, a European initiative, and we were very happy to collect data, roughly 1,300 cases from 7 centers across Europe, from high volume centers, and we analyzed those data extensively together with Boris Schmidt, together with Stefano Bordini, and all the co-workers from all contributing centers. And we are very lucky and we feel very happy to present the data as a late breaker at HRS this year in New Orleans.
Yeah, looking forward to hearing that.
Yeah.
That is all focused, as it were, on FARAPULSE PFA, is that correct?
Yes,
So
absolutely.
do you think that data is extrapolatable to other types of PFA, or is it specific to FARAPULSE?
Another very good question. I think this data, of course, do refer to the way we deliver the electroporation in catheter ablation of atrial fibrillation. So therefore, I would think it is not directly extrapolate, or we cannot extrapolate for other technologies. So PFA is not PFA, that's what I'm saying.
So you think it's fairly specific
it is specific,
to that?
Yeah.
Okay.
From my opinion, it is specific, yeah.
What have been the principal learnings that you've had with respect to PFA in terms of your workflow and patient management?
Yeah, I cannot share too many details from the Euphoria registry. So we need to wait, of course, for the late breaker.
I meant in terms of your own personal clinical practice.
But in my personal clinical practice, we have been, or the procedure times are characterized to be very fast and very efficient, and it's not that much dependent on the operator. So to give us a picture, even at Friday afternoon, if I have to do some work in my office, 2 of my younger colleagues can easily do cases, and we still would go home by time and start the weekend.
So predictability, usability, safety, effectiveness?
Yeah, effectiveness is...
Without compromising any of the data?
Yeah, effectiveness, I can refer to our own data, which we looked into, and we also presented some comparable data. It is very much in line with what we expect. So after 1 year, In paroxysmal atrial fibrillation, we have 80% plus sinus rhythm. In persistent atrial fibrillation, we have 70% plus for the FARAPULSE PVI. So this is exactly the number I would expect from a good and solid PVI procedure.
So very consistent with Manifest, for example.
With Manifest, and looking also into the redo data. I think this is also interesting because using our 5S approach, a simplified and streamlined approach, we still observe a very high rate of durable PVI. More than 90% of PVs being durably isolated, more than 70% of patients coming back, all veins electrically isolated.
Very interesting. Can you just expand a bit more on that research project that you undertook, the mapping processes? What did you do? What did you find?
We were, of course, very eager to understand if a patient after an index FARAPULSE PVI procedure came back with a fib recurrence or atrial recurrence. And we took 25 patients back and did a very careful analysis, and we did a high resolution map in the second procedure to really understand what are the levels of isolation, which vein is isolated, etc. All these details. And we found, as I mentioned before, more than 70% of patients, all veins isolated, more than 90% of veins durably isolated.
So how big a step do you think is FARAPULSE in the world of ablation, given your clinical experience?
Yeah, I mean, when we've been discussing workflows, and due to the very short procedure times, I have to say, not only short, very short procedure times, we are getting somewhat even in the range of an electrical cardioversion these days. This may sound a little provocative, but we are able to do numerically more cases per day as compared to, let's say, a standard care of or running a standard AF ablation program.
Yeah, patient experience. We've talked about effectiveness, the efficiency, the safety. What do the patients feel about it?
I think patients today are very well informed. So many patients, they specifically ask for the FARAPULSE catheter because they want to have a non-thermal treatment. And in the post-ablation course, it is, I would say, it is pretty uneventful. Even a couple of cases we did with same-day discharge, so it works.
Is that becoming part of your usual practice nowadays cases? Because I know things are changing a bit in Germany in terms of reimbursement.
Same-day care will become within the next years, at least in part, for selected patients, standard of care, even in Germany. I am convinced.
And particular patient groups, PVI, de novo, for PAF, what about persistent AF patients?
Yeah, I think in the very first procedure, in the index ablation procedure, PVI, which is the standard of care at this point in time. But patients who come back after previously failed RF procedures or cryo procedures, I think it may make sense to, or even also after FARAPULSE procedures, to do more than just PVI, because as I said, many patients today, they come back with all veins isolated, and then posterior wall isolation, of course, is a target which could be is very interesting, but we need more data.
Exactly, and as you know, that's not on label for Boston at the moment.
Oh yeah.
But there is real efforts going on with ongoing research to evaluate that and its clinical safety and efficacy.
Right.
Well, Julian, fantastic. That's been a really good insight into your clinical experience, your understanding of where PFA sits in the clinical armamentarium. Very grateful to you for spending some time talking today, and look forward to hearing more, and very grateful to you for your ongoing research efforts contributing to the field.
Thank you very much. Thanks for having me. It was a pleasure.
Great to see you.